documentation and assessment. It's a must for both professions. If we compare PT and OT, we either treat the patient by standing order or getting referrals from the physician. We have something called initial assessment for both adults and pediatrics, and we have an approved printed materials for that's approved by the Ministry of Health called PT4 and PT5. And we have to write the discharge summary and the patient status. And of course, we have something called initial assessment specifically for pre-operative kind of patients. For the OT?
For OT, we are primarily taking referrals as our mode of starting the treatment. Only in Ibn Sina is the first place that we've started standing order in ICU. And we do have many standard and non-standard assessments. So some of the standard assessments are jotted here. So we do initial assessments, we do discharge plans, we use SOAP notes as the international standard to record the progress of the patient and so forth.
Okay. Now, for the outcome measures, we will here just give you examples of the outcome measures both professions using. For physiotherapy, we are using self-report measures. This is mostly done through questionnaires, performance-based measures, generic measures, for example, the Barthel Index, the FEM, the Berg Balance Scale, and the time jump and go. And we have disease-specific kind of measure that you can only use it, this outcome measure, for a specific kind of population, like for a stroke, we are using the stream and the mass.
So basically, as it's probably the same, but we would be more quantitative or qualitative and descriptive in how we assess the patients.
Okay. Treatment strategies. What do you think? You already mentioned that kind of previously in this lecture when we talked about. Let me just wait. What do you think? How each profession is treating the patient? What strategy do they depend on? So each one of us depends on. Any idea? Physiotherapist? Occupational therapist? Okay. Does that ring any bell? No? No? Okay.
We do movement and quality, right?
No. We are using something called the bottom-up approach. And in occupational therapy, they are using the top-down approach. What does that mean? For physiotherapy, bottom-up approach. We're starting on the lower level. What does that mean? Give me an example.
On the weak points.
Working with okay, deficits and impairments or limitations that the patient is having in order for us to get the goal. So we're working from bottom. If the patient cannot walk, I will not take the patient and make him walk. I have to know why the patient is not walking. Break down this problem into different impairments. For example, what's stopping the patient from walking? For physiotherapists? Muscle power, motor control, balance, okay? Sensation problems, tone problems, okay? So we're working on these. So at the end, we will make the patient walk. This is the function that we want, okay? So we're starting from bottom up. Is that clear?
Yes, so if all the impairments that you see in a patient are at the bottom row, the performance or productivity will be the last target. So we start from performance of the patient and then we go downwards. So if a patient, his performance is, if he's a sports guy, right? So he would go to the physiotherapist saying, I have a pain or I have an injury. So I would look at his performance. Is he able to play tennis or not? Whereas they would actually treat the injury as such.
Yeah, so if he has pain, we have to work on the pain. If he has limitation in movement, we have to work on the limitation. This kind of stuff. Does that make any sense for you? Okay? Yeah, so the kind of strategies we use are opposite, but at the end, we reach the same goal for the patients. Let me give you further elaboration on that. If we're talking about the basics of practice, and one of the most important things is evidence-based kind of a practice. We treat our patient based on evidence, okay? So, if we start with the basic of practice, we have to diagnose, manage movement dysfunction, and enhance physical and functional abilities to start with. And then we have to restore, maintain, and promote not only optimal physical function, but optimal wellness and movement, and health. Last but not least, prevent the onset, symptoms, and progression of the impairments, functional limitations, and disabilities that may result from disease, disorder, conditions, or injuries. Okay? So these are the main kind of basics that we are using in our practice of the profession as a physiotherapist. If we're talking about evidence-based practice, anybody here does not know what does it mean? Evidence-based practice? Physiotherapists, they should know, and I believe also the occupational therapists. For others, that means if you're practicing something, or if you are doing a treatment, you have to have an evidence from that method. You have to have studies, good quality, with good quality, and also researches to prove that you are doing good for your patient. So, the type of evidence is also different. We are using a traffic light for the evidence. If it's effective, we will go ahead and treat the patient. But if by the evidence it was proven to be uncertain, the result that you might have from this kind of a treatment, then maybe you should consider after other treatments. And last, if it's not effective and you continue to use it, it's not ethical. So you should not use or administrate this kind of treatment. You should look for something else. Okay?
So from the 21st century, there has been a high demand of evidence-based. So evidence-based is not only in the physical therapy, but also in the occupational therapy and in the medical field as such. So I'm going to just go as an overview as to what we do here in Sina, treating neurological and neurosurgical patients. So we mainly focus on their attention or their alertness, because most of the patients come in post-surgically, they're in a coma, and they have they're either comatose or semi-conscious, so we want them to be more alert. And then we go into their feeding assessments. We look into whether the patient can swallow well or not, and if further required, we even contact a speech therapist or a phoniatrist to help them to swallow better. And then we look into their cognitive skills, which is their memory, their attention, whether they're able to perform their skills, they have a cognizant awareness of what is happening to them. We also look into their hand skills in more detail, whether they can perform skills like writing, putting on their buttons, putting on zips, or even to use marbles, for example. And we, as I already mentioned, we look into their self-care aspects. So self-care is not only brushing, bathing, toileting. Self-care is also doing instrumental stuff like going to the market, or doing a shopping list and going and purchasing stuff, or communicating, calling somebody up, writing a letter, or using the computer. So these are all instrumental self-care. And finally, productivity. So if a person wants to go from one place to another, he's going to use a wheelchair. How is he going to transfer himself into a car? Or if he's living in the third floor, he does not have a lift in the house, how is he going to go home to his apartment? So we look at all these things and help the person to reach a maximum level of independence. So we start off remediating most of the skills that a patient needs. And then if we're not able to remediate those skills, there's an issue with his prognosis level. We go into compensatory techniques like providing adaptive devices, providing aids, providing functional splints for the patient to be maximum independent.
So, let's summarize together everything that we just said in this lecture. Things we both share. What we just said. What do you think? The overlaps or the similarities between the two professions. Let's talk about education. Okay. Mode of treatment. Function. Probably you forgot. Forgot already? Okay. We are giving you here a schedule to summarize for you. It might be easier for you to know and to remember what are the similarities and the differences between the two professions. If we talk about education, we both should have Bachelor of Science and a training degree. The specialties that are common between the two professions are neurology, pediatrics, orthopedics, older adults, burns, oncology, and cardiology. But cardiology is not yet implemented before the OT here in Kuwait. We have subspecialties, we share hand therapy and scar management, as we both deal with this kind of patients. For the assessment and outcome measures, each must evaluate subjectively and objectively. The type of assessment, the type of documentation is definitely different, but we both have to document. And for the treatment, the goals are identified with the treatment plan to achieve it. What is the problems, how it's written, and what are the treatment plan, it's totally different. But we both have to do these two things, right? This is for the similarities. If we talk about things that we do not share, don't look into your paper and tell me one thing that way. Don't look into your paper. Don't look into it. Don't look into your paper. Okay. There are some differences, clear differences, right? Okay. Activities. There are working activities. We're working on water function or mobility. Any else? What else?
Starting from bottom to
yes, the approach, totally opposite. Yes. Okay. Outcome measures are a little bit different. Okay. We talked about function. For the PTs, we are working more on motor function.
And performance.
For the OTs. For the approach baseline, we are solving the impairment to overcome the disability.
But here we're looking at function.
Okay. The specialties that are different, cardiopulmonary, sports injuries, women's health, and electrotherapy, they do not have it in OT. Okay? And for the OT?
We have, okay, I'm just putting a tease line here. I think we can also explore other options, you know, so we're free to explore and they're free to explore, so it's not like we cannot do that, but yes, exactly. Why not? Yeah, why not? So you're always welcome, you know. So there's mental health, community medicine, forensic science, ergonomics.
These are kind of factors that we consider, but we don't directly address. This is what I meant. Okay? The subspecialty, almost everything is different. Okay? And for the assessment forms, we already, mashallah, we have forms from the Ministry of Health, and I hope, inshallah, for the OT, they are working on it to have a formal forms from the Ministry of Health. For the treatment, who said they're working from bottom and down? Yeah, a superhero. Okay. So working from bottom to up, but
And
for
top
the
to down from
making any sense? Do you know the difference?
Excuse me.
One more, we will have one more elaboration, and then by the end we can ask questions.
Not a question. You said one of the differences that electrotherapy is not used by the OTs. We are, as a teaching staff in the university, we are teaching the OT students some of the electrical modalities,
Like what?
like chemical agents, which is called and paraphenols, and the ultrasound. I'm teaching them now.
This is a
So
conference.
they are using.
It is.
I don't know, but the previous, I think,
The
3 or
OT
4
part, taken
years.
from the OT, not from the...
3 or 4 years, last 3
The
or 4
problem because
years,
Jeeva is not Kuwait University graduate, maybe...
ultrasound. There are some places where they use ultrasound, but then you should be officially trained to do that.
yeah,
so
lecture and the practical sessions.
A bachelor in occupational therapy cannot perform an ultrasound unless they've had a specialized training for an ultrasound.
But they have the part
What
of
else?
the same.
Yeah, the
Yeah.
certificate, yeah. But sometimes implements like the hot bath, cold bath, like these, we are familiar and implemented. But for ultrasound, these stuff, we are not much working with ultrasound. Not that much.
Anybody from the OT is already licensed and already graduated. You are using any electrotherapy now with your patients?
Sometimes in hand clinic, yes, they are using.
We do functional electrical stimulation, FES, which is a very mild form of stimuli for flaccid limbs.
But if you compare it to PT, we are taking full
Exactly, yeah.
Okay. Let's start the video. This is summary.
Welcome to Sterling Physical Therapy. I'm Dr. Sterling Carter. Today we're going to cover the difference between occupational therapy and physical therapy. Occupational therapists treat and assess conditions that affect a patient's ability to perform daily tasks. These tasks include self-care to high-level activities that can even be job-related. In addition to assessing and treating these conditions, occupational therapists, or OTs, design treatment plans that help patients with functional activities to improve cognitive, visual skills, and general coordination skills. Overall, the goal of occupational therapy is to help patients function with the highest level of independence possible. Physical therapists are healthcare professionals that use specifically designed exercises and equipment to help patients regain or improve quality of life. We diagnose and treat patients of all ages with injuries that limit a patient's ability to move and perform various activities in daily life. As a physical therapist, one of my passions is developing a personalized plan using different treatment techniques to promote increased mobility, reduce pain, restore function, and even prevent disability. Our fitness and wellness programs help our patients develop healthier and more active lifestyles. I hope this information was helpful to you.
Was helpful? Yes. Okay. So I think that's it. We are open now for discussion. This is not a debate. This is just to clarify the differences and the similarities between the two professions. We are not here to fight with each other. We are just here to clarify things that probably some of you were not aware of. I hope it was informative, it was answering some of your questions, and we are now open for any questions anybody has.
Can I?
Yes?
Thank you for this beautiful lecture, but I refer back to the first scene, the acting scenes happen, which is actually true. It's happened.
Really?
Really. But not in front of the patient, behind the patient. But
No,
my
we know
question-
where you are from.
Yes.
Okay. Anybody else has the same kind
Well,
of
I see the war starting among students now.
Yes, among students now, exactly.
And it is
So-
sadly the same.
So my question, the time of occupational interfere with patient treatment.
Okay.
When you are supposed to interfere, do you have to start with acute stage of the patient while he's still in bed?
We start even in the ICU.
Yes. They start in the ICU.
This is the conflict now.
But I don't think it's implemented in any other hospital but in Sina. Are there any OTs seeing patients in ICU? Or no?
We have a neonatal ICU feeding only.
Only feeding for
Feeding
pediatrics.
For pediatrics.
And we have it also for adults. Okay. Okay.
Dr. Yasser wants to say
So
something.
I believe that multidisciplinary approach is always the best thing for patient care.
Sure.
And it should start all the way from the critical care units throughout, the acute phase. And I've seen differences when we do multidisciplinary worldwide. And this is a message, especially from a neurocritical care point of view. Even if you guys don't see immediate effects, make sure that you keep in mind that when you start in the ICU, it's going to be translating to the ward, it's going to be translating to the outpatient clinic. And it decreases length of stay, it improves the outcome of the patient, and so on. Now, the other question is, how are we going to measure metrics on an outpatient point of view, 6 months or 1 year after the stroke and any further? And at that point, are we able to give like standard metric to say, yes, this therapy improved this or that therapy improved that? So maybe in 5 years down the line, we'll be able to answer that question. But it should start early, and I've always encouraged it to start early. And it's been done many years ago.
Yeah,
in the ICU.
but I'm considering the part of the patient itself. If I do my own treatment and the occupational therapists come and also do their own treatment, the patient.
That's why there's a like, for example, you're talking about limb physiotherapy, right?
For example.
Yeah.
For example, you move the patient outside the bed, start walking, or the physiotherapist, she'll make the patient walk. And you're going to come back again after the physiotherapist and make the patient walk.
Yeah, so my goal is I'm not going to actually make a patient walk. My goal will be to take the patient to the toilet and do a dressing activity, for example.
Functional.
Functional.
Okay.
So in order to achieve that, I have to do step 1, step 2, step 3. So probably if I'm doing step 2, the physio might think that, why is she doing my job? So we break down an activity, like the functional activity, into say 5 or 10 steps. So each step the patient cannot do all the 10 steps together. So we break down activities and we train them step 1. So we see which is the activity that the patient can perform and which activity he cannot perform. So if say in 10 steps he can perform 5 different steps, so we train him individually for each step, and then we combine all the steps together to be able to perform the final step.
Like analyzing that.
Exactly. So it's called activity analysis. We analyze each activity that the patient wants to do, and we help him to regain the final product. So probably if I'm doing step 2, which is like walking towards the toilet, it might feel like I'm overlapping, but I'm not really assessing his gait, and I'm not assessing his posture. So that's when I need a PT to be by my side to help the patient in that process to work on his posture, gait, balance. So I'm only focusing on the end product. So we do combined therapy in Sina, and we really encourage all the hospitals to go for combined therapy.
We're having joint sessions for PT and OT at the same time. For example, the PT will be working on making the patient having more motor control, but the patient is not fully alert. And the occupational therapist will be working at the same time on using their own strategies, for making them more alert. So we can actually benefit the patient more if we are sometimes having joint session, and we're doing that already. We should not think of it as 2 different professions, and we are working against each other. We are working together for the patient's sake. So the patient needs the OT. Sometimes we ask in the OT if the patient is having. We one time had a patient who was actually a child who was totally refusing any physiotherapy intervention after surgery. We wanted the patient to be out of bed and walk. So we asked the OT to come and try to calm the patient, and they're using their own strategies, cognitive ways, to calm the patient in order for them to be convinced so they can accept the orders or the commands by the physiotherapist. So we are doing joint sessions all the time because we are not thinking about ourselves. No, my job is better or my job is more effective. No, we are not thinking like that. It's for the sake of the patient, the benefit of the patient. Yes, Carlos. The devil.
One of the most common things we do in the ICU, I'm in the ICU here, is that the physiotherapist would want to make the patient do sitting balance and tolerance, okay? And the OT, while I'm doing the sitting tolerance training or activity, would be doing cognitive stimulation or something hand function. So we do both in
there's a lot of discussion between the OTs and PTs, so there's less overlapping. Good.
We have a question here.
Even in our ward, I am neurological department, ward 7, female. We just, even the time of session, we collaborate, and me and Jeeva, or the OT, okay, about the timing. Her session time, my session time. Okay, what exactly she need to focus. We will have a meeting, small meeting or discussion about what exactly she wants, her plan according to the patient, and what my plan. So we try to meet in one point that the patient.
I think they got the idea now. Okay. Anybody else has any comments?
We may
Yes,
work with the patient, transparent patient comes to find to sit, to stand. Our purpose may be for motor planning or for depth perception. So the goal is not necessarily to be on motor or physical aspect. We may work on cognition, psychological side, or perception.
Yes. So this conflict between starting now in Australia and from the student level should stop. Maybe we should get something.
Yeah, it must be collaboration
Why?
between us.
And they're thinking that we are opposing each other or what? We are in a fight, somebody's gonna win. It's not about winning. Okay? We are all
You are an idea, actually.
we are all professionals and we should work together. The goal
Maybe Dr. Talan can give us more insights as to why there are conflicts in the university.
Please.
Again, ego. PTs, they see themselves higher, and the OT coming out of PT. And then,
So it's a myth, basically, that OT came out
It's
of.
all about history, like our life, religion, and all the fights
And we are
about history.
outnumbered also. We are outnumbered.
And we are outnumbered.
So they think about the minor
They
things.
work under the umbrella of physical therapy in the same department of physical therapy. So PTs, they see themselves higher. OTs, they have a reaction against that.
Defense
Again,
mechanism.
the ego, we are better, we study more, and we deal with mental things, and we rather be anything else than PT. When Muslim said it in the class, he said, I'd rather to be anything else instead of
The OTs
OT.
are haram.
My experience,
They hate us now.
I work in pediatrics as you mentioned, doctor. One patient had 9-year-old female Kuwaiti. She admitted 1 month ago for admission for dysnostomy, but patient has hysterical by seeing the white coat. She not allow anyone to the treatment. But finally, Dr. Sarah, she is helped a lot by mental health. Then today, last week she got operated. Dysnostomy closed. Today she is going to be discharged, inshallah.
She accepted both of you.
Yeah. Because of start with OT only, then only she's allowing. Without her, we cannot get it anything.
So my final advice, don't think about the minor.
Work as a team, together.
Teamwork.
You
Yeah,
cannot
teamwork.
separate
It's not about
No
fighting
way
with
to
each other,
separate.
proving that the other side is wrong and the other side is right. It's not about that. You let the minor things let them go by. Inshallah, both of us. Why should not both of us be higher and on the top? Why there should be only one? Both of us, okay, for the sake of the patient. I understand you speak language is not coming the way, but we have to have the 3 T's, huh? Therapy, occupational therapy, and speech therapy. They will collaborate together. I think
one another suggestion was like instead of having a physical therapy association separate from OT association, it's better to combine the both OT-PT association. So when you're one, it's just a suggestion which you can take it on to your, so if you have one association, I think people will have.
We only have 25, which is we're working on that. We're working hard on that. Really. Yes, Sarah.
We are working with them mentally or psychologically. It's better for the patient to adapt significantly different stimulants like nursing, staff, physiotherapy, and also, as Dr. Rami said, the patient was so scared from anyone wearing white. So actually, it's our job for the best of the patient to make the patient accept all of the things. So yeah.
In my final examination in the university, I had a pediatric patient in my final exam. All the time she was just crying, and this is my final. I was very nervous. Then I clicked to my mind and I took off the coat. I started playing with the patient. The whole session went by, I'm just playing with the patient, trying to calm her down. And I said, I'm definitely going to fail this exam. Because I didn't do any assessment, I didn't do any treatment. But the fact is, the university examiner, he gave me an A. Because you're caring about the patient, not about the exam. And this is the most important thing. We will give you another chance to do another assessment and treatment, but for now you took an A, because you took care of the patient. So always think about the patient, because others might think, I don't have time, even if she's crying, the hell with that, let's do the examination, let's do the problems, and let's do some treatment. Otherwise I will get ahead. Okay? But I didn't. All the time I was just playing with the patient. And I took off my coat. And she was calm at the end, but by the time
Too
she
late.
was calm, it was the end of my examination. So care about your patients. And in order for you to care about your patients, is to work
Together.
together. Yes. Okay, so to go on this, we're going to